Hello, this is Group 8 Ethics Committee Project, and my name is Shamiko Lebo.
Mark here.
Hi, this is Group 8, and my name is Chanel Kimsel.
Just a brief outline here of the presentation. We're going to go into a summary of the case, followed by each role's perspective on the case. Then we're going to go into the box module, talking about the medical indications, the patient's preferences, quality of life, the contextual features. Then we're going to go into the group recommendation, and then end with each group member's reflection.
Ms. Johnson is a 73-year-old woman who lives with her son in Pennsylvania. She was previously independent and has a history of poorly controlled heart failure with multiple hospital admissions. She goes to the ER confused about the date and her location, but she knows her name, and imaging shows a small bowel perforation and her blood pressure is extremely low. After IV fluids, her mental status improves enough for a discussion with the surgeon. The surgeon explains that the surgery is the only treatment that could save her life, although her chances of surviving the operation are estimated at 20% due to her weakened heart and malnutrition. Ms. Johnson states that she absolutely wants to go home, have dinner, and die peacefully there. She also tells the team not to contact her son. She cannot fully explain her condition or the consequences of refusing surgery. Her condition worsens overnight and she becomes unable to speak. The surgeon contacts her son to inform him of her critical status, and he explains that there's no living will and he is the youngest of four children. The next morning, Miss Johnson becomes alert again and is extremely upset that her son was contacted against her wishes. She continues to refuse surgery, but her son insists that surgery should be done. The case raises significant ethical and legal questions about decision making capacity, patient autonomy, surrogate authority, family conflict, and the role a healthcare provider and their team should take when life saving treatment is available, but the patient appears to be unable to give an informed refusal or informed consent.
Hi, everyone. My name is Chanel Kimsel, and I'm speaking from the chaplain's perspective in this case. So my focus for Miss Johnson is her spiritual and emotional needs and what her choices might mean on a deeper level. When I look at her situation, what really stands out to me is how she constantly is always saying, like, she wants to go home, she wants to have dinner, she wants to die at home. Those aren't random statements. That sounds like someone who is tired and someone who is dealing with chronic illness, who has dealt with chronic illness for a very long time, and someone who may already reached a place of acceptance that they're ready to go. So there's a very human, very spiritual layer of that. My role in a moment like this will be to explore the meaning behind her wishes. Home often symbolizes comfort, control, and dignity. So for a lot of patients, I feel like that home represents the last place that they would like to be at, where they feel like themselves. Wanting to die at home can be could be a way of saying, I don't want to suffer anymore. I don't want my life to end at a hospital bed. Those themes are important spiritually, especially for someone who describes herself as being at peace with the idea of passing. Another big part of this case is her Catholic background. In Catholic teaching, there's no requirement to pursue treatments that are considered overly burdensome. So it's unlikely to provide real benefit. So even though the surgeon says surgery is the only chance of survival, the fact that her chances are so low, around 20%, places the treatment in a category the church often calls disappropriate. So those are types of treatments or morally optional, non-mandatory. So choosing comfort, focus, care, prayer over receiving anointing of the sick is completely consistent in her faith tradition. There's a lot going on emotionally with her relationship with her son. She did not want Brian contacted, and we don't know exactly why. Sometimes that's about not wanting to worry a child or have them see you the way you are. As a chaplain, I would want to gently explore that, not to challenge her, but to understand what she needs and what she fears. And for Brian, his reaction to make sense too. He's scared, he's overwhelmed. He doesn't want his mom to go. And when a doctor tells you that your family member has a 20% chance of survival, that kind of like that hurts, that scares you. And he's not trying to go against her wishes, and he's acting out of love and fear. Part of my job is to help him process what's going on. There are also
As the ethicist of our group, my role is to analyze how the healthcare team should balance respect for Ms. Johnson's autonomy while also maintaining benefits and non maleficence. This case presents a conflict between the patient's stated wishes and her fluctuating decision making capacity, as well as the family's desire for life saving treatment. The questions that we have to answer is whether or not she has the capacity to refuse surgery and whether her decision aligns with her values. So, current literature on older adults emphasizes that capacity isn't just taken away because the patient is elderly or experiencing medical stress. Marx and his colleagues explain that ethical care for older adults requires us to be respectful for their personal goals, their values, and their sense of dignity, even when the medical choice is high risk. And considering the surgery is only 20% survival rate, I would consider that high risk. So their work highlights the autonomy remains central as long as the patient understands the situation well enough to communicate a consistent choice. So for Ms. Johnson, there is evidence of a stable preference. When she was becoming more alert after the fluid, she began to understand that surgery was risky and she expressed a desire to go home and die peacefully. And this preference kind of aligns with her identity as a practicing Catholic who feels spiritually prepared for death. Even though her medical condition worsened overnight, the earlier conversation still allows us to evaluate her intention. So ethically, our first responsibility is to determine capacity. If she is capable, then her decision should be honored because it reflects her values and her understanding of what matters most at the end of her life. If she were to be found at a lack of capacity, the decision would shift to a legal surrogate. But even then, the surrogate and the care team would use a shared decision making capacity. And rather than just forcing treatment, they would consider the values she expressed when she was lucid. So, overall, the ethical conclusion is that respecting her dignity means taking her voice seriously. Her wishes and her spiritual beliefs and her comfort should guide the care plan.
Okay, from the legal or the attorney perspective here, very important document we have on the left-hand side. It is the Pennsylvania State Law 2006 Act number 169. There were two statutes under it. Specifically, we're looking under Title 20, which is subsection 5461 under Section D. We'll reference it here in a moment. But before we proceed, we have to define two very important terms: capacity versus competency. Bottom line, competency is court ordered, meaning the patient is not able to make decisions on their own. So therefore, it is court appointed that somebody else will for them. And so capacity is when a healthcare provider is able to say, hey, this patient does not understand what is going on. They cannot fully make an informed decision for their health. So then therefore it would be have it made for by somebody else. Specifically, the case highlights that there were no legal documents in place, meaning no healthcare power of attorney or living will. So no power of attorney. She did not designate anybody should anything happen to make decisions for her, and then no living will. So helping realize what the patient wants if for her decisions and her wishes. And so then it would go to the hierarchy, which is outlined here in the act, and it would go to a spouse. There's no spouse, so then it goes to adult children. There's 4 adult children, and Brian's the one present there. So if there was no adult children, it would go to the parents, and if there's no adult parents there, then adult siblings. No adult siblings, then adult grandchildren. No adult grandchildren, then any adult with knowledge of principles and values that the patient would want. But so we are at now the Brian being the person making the decision again, and this is all to do with whether the patient is at capacity or not. So if the patient is ruled not to be at capacity to make their own healthcare decisions, to know what's going on, then the decision would go to Brian, which this is implied here at one point when it says she cannot explain why she does not want her son contacted, nor can she show full understanding of her current condition or the consequences of refusing surgery. So she is at that point not at capacity. So up to there, Brian gets to the next day, and Brian says he wants surgery. If the patient does not come back to be at capacity, then she cannot make the decision. But very important here under section 5461, subsection I, paragraph 2, and that states, regardless of the principal's mental and or physical capacity, a principal may countermand a healthcare decision made by the principal's healthcare representative that would withhold or withdraw life sustaining treatment. So it's going to come down to here, is this bowel perforation surgery a life sustaining treatment or is it a life saving treatment? And so there's a section there under section 5422 which gives definitions, and it states that when administered to a patient or principal who has an end-stage medical condition or is permanently unconscious, will serve to only prolong the process of dying. So this is what a life-sustaining treatment is. So this is not quite to what a life-saving treatment, because the bowel perforation is an emergency and needs to be taken care of. So if this does not happen, then the patient is not going to live for very long. So again, it's all going to depend on whether she's at capacity. And very important, the last sentence of the case here. Next morning, Ms. Johnson is awake and upset that Brian was told about her condition. So it's almost implied that the patient is at capacity. So again, it's up to the healthcare providers there to decide whether Mrs. Johnson is at capacity. And if she is, then it doesn't matter. She could refuse anything she wants, regardless of the mental state or her physical state. If she does not want the surgery, she does not have to get the surgery.
As we look into the medical indications, Ms. Johnson's condition is extremely serious. A small bowel perforation is a life-threatening emergency because the contents of the intestine leak into the abdomen, which quickly leads to infection, inflammation, sepsis. Without surgical repair, the condition progresses rapidly and is almost always fatal. So surgery is the only option that offers any possibility of survival, but that possibility is small. And Ms. Johnson has several factors that make the procedure extremely high risk. Her heart condition is barely functioning, it's already weak, and due to the advanced heart failure, she is also malnourished as well. So both of these conditions reduce her ability to tolerate anesthesia and recover from a major operation. So medically, we have the situation where we are trying to provide life-saving treatment through surgery, but the likelihood of survival is incredibly low and the risk is significant. So this creates a foundation for the ethical and the legal challenges that we're discussing in this case, because the medical team needs to weigh the urgency for the condition with respect for Ms. Johnson's preference and values. And also considering that the likelihood of her surviving this is very small, we also have to weigh the fact that, doing more harm with the surgery is a possibility as well.
Patient preferences. So this is what the patient wanted, patient's wishes per se. The case had highlighted all this, but one important thing to note was that there was no records of advance directives, meaning no medical power of attorney or living will. So nothing was unfortunately in writing, but it did not thankfully come to that situation. This could have been a lot worse had she arrived and not been alert at all throughout this entire process. Could have made things a lot more difficult, but thankfully that was not the case. And she was able to verbalize, and she had said to the doctors that I'm at peace with dying. This having to do likely with her religion, being a Catholic. So, she probably has a strong relationship with Christ and understands that this is not the end and life is eternal with Christ. So that I'm sure that had a heavy influence here on her decision of not wanting to go through any more procedures or get any more treatment. She was just ready to go home and die, as she said. But with that too, I think even potentially if it was a higher percentage of like a 20%, it just kind of sounds like she was done. And again, she's at peace with her decision. So I don't think, even if the surgery chances were better, that it would have changed really what she wanted. But most importantly to note here too, she did not want the son contacted. So she had stated that, but again, as we saw in the case, how things played out, The medical team did follow the Pennsylvania state law for who to contact next and the situation that they were at, because this is technically a medical emergency, having a perforated bowel. So, but who knows really why this case could have been like this. Maybe she knew that he would be resentful and want her to get this procedure no matter what she said. So, okay, quality of life for Mrs. Johnson. Not looking so great based off the details of the case. Poor heart function, we have malnutrition, and now we have this bowel perforation, which is something that's very serious. And at that, it's a 20% survival of the surgery to even survive it. And if she survives it, what's the quality of life going to look for after that, given the other comorbidities and such? And so, bowel perforation, right? It's the contents of the bowel is just going to keep leaking, and it's going to lead to sepsis, inflammation, and multi-organ failure. So, at that, the patient maybe days, weeks if things are lucky. But so that's why I thought it was important to look into hospice and stage of care. And hospice is they're the experts in helping keep the patients comfortable towards the end of their life here. And so the patient stated that she wants to go home and die. So this would be something very important to have set up for the patient, and usually can get done really quickly, just as long as no insurance issues. But so I found this one here called Pinnacle Catholic Hospice Care. So probably share a lot of the Catholic values and some things you could look forward to speaking to them about. But so these guys they'll take over the care. They would be the ones to order any meds and such and help look after her, because if she just goes home without this, she's just going to end up needing to come back to the emergency room because of a pain or the symptoms. So she's gonna need some kind of care outside. And especially if she's ready to die, then hospice is a wonderful option for them to look into. And there's two options. They have inpatient, where they can go to a facility, or they can go in the outpatient. Most importantly for this case, though, after evaluating it, she's probably going to need 24-hour care based off of the bowel perforation and such. So if they're able to offer the 24-hour care in the outpatient, great. They can get a hospital bed into her house, and then have 24-hour care, and it's a win-win. The patient gets to pass peacefully at home. If not, they should be really looking into an inpatient. But hospice would be the most dignifying way to probably go for the patient without having to be suffering at the end.
For the contextual features, we looked at the legal, family, and the spiritual factors surrounding Ms. Johnson's situation. One of the biggest issues is that she does not have an advance directive or designated healthcare proxy, and because of that, she lacks the ability to make decisions. And because of that, the medical team has to turn it over to the state and identify a legal surrogate. And in the state of Pennsylvania, all adult children can act as a surrogate, which is why her son Brian was brought into the situation when she became unresponsive. So even though she originally stated she didn't want him involved, the team had no choice but to turn over to someone since she could no longer speak for herself. Ethically, it would be ideal to involve all children, not just Brian, especially since he's the youngest one. The others may have insight into her long-term wishes. The goal is to avoid making decisions based on one family member's fear or urgency, and instead focus on what Ms. Johnson really wants. Another key factor that played a role was her Catholic background. According to Catholic teaching, patients are not morally required to accept treatments that are extremely burdensome or unlikely to provide real benefit. So declining a high-risk surgery with a low survival chance fits within the framework. So spiritually, her refusal is not incompatible to her beliefs, and it may actually reflect them. There's also the tension between her expressed desire for privacy and the hospital's duty to protect her when she became critically ill. The call to Brian wasn't intended to go against her wishes. It was made because she was unstable and unable to advocate for herself. Alrighty, so our group reached a decision on the recommendation based on all the information that we have examined and explored with Ms. Johnson's expressed intentions, the legal requirements, and her spiritual background. Reevaluating her ability to make decisions at her current state of attention is the first step. Although capacity can change, her decisions should be honored if she now is able to comprehend her illness. And even the life sustaining therapy is likely to result in death. Patients have the freedom to decline that. Her adult children serve as legal surrogates in the event that she lacks capacity. However, even in that case, we think the surrogate decision should be based on her beliefs, which have been stated time after time, and preferring serenity, avoiding aggressive treatment, and becoming spiritually ready for natural death. For her situation, there is a high risk of more suffering and a very limited possibility of benefit from surgery. As a result, we do not consider surgery to be morally necessary and it might not align with her personal preferences. For these reasons, our group recommends shifting the focus toward comfort centered care rather than rather than her being in a hospital doing surgery. Um, this would include support, managing her systems, and addressing her spiritual needs as a Catholic patient. We also recommend involving all of her children in the communication so decisions aren't shared and the family has support during this time. Overall, the plan that best aligns with her values and the ethical principles um, and non and the honor her wishes for a peaceful, dignified end of life experience.
Working through this case taught me how challenging ethical decision making can really be when a patient's medical needs conflict with their personal values, their family expectations, etc. Before this course, I thought decision making situations were not that challenging. Now I understand that ethics requires us to take a deeper look into a person's life, their belief, their experiences, and how they determine dignity at the end of their life. This case helped me reflect on my own assumptions because I realized I was naturally leaning one way based on my own preferences. But this assignment reminded me that ethical right choices is not always the one that prolongs life. So sometimes the right choice is the one that protects the patient's autonomy and honors their most important values and what matters to them. So I always saw the concepts that we learned throughout the class, like incorporated in this assignment, like the capacity assignment, shared decision making, and the 4 box module. It gave structure to situations that feel emotional and overwhelming. As a future provider, especially working with diverse populations, like I hope to in the future, I feel more prepared to approach these situations and these conversations with a lot more empathy and a stronger understanding of how to balance medical facts with personal values because this assignment made me more aware of the responsibility we have to truly listen to patients and advocate for their dignity.
So after going through and doing this ethics committee presentation, I learned quite a bit. Was able to reflect a little bit on it. And first point, I don't think I'd actually ever looked at one of these like statutes or acts, legal documents. So it was quite a learning experience, kind of looking at that. At first, it looked very daunting, but once you realize what you're looking at and how everything's broken up and very organized into the subsections and you can have a section for the definitions so that there's no discrepancies. So it was quite interesting being able to see how all that is laid out, and it's very important that it's all laid out in detail. So second thing, probably the significance of the advanced directives. Tomorrow's not promised for anybody, and God forbid something happen. So to take the guesswork away of anybody not like knowing what your wishes are and such. So it's always great to have these things in advance and planned. So it's just very important. It was an unfortunate situation with Miss Johnson, but I think we came to a good group decision on how to handle it best based off of how everything had played out. And then, lastly here, just a lot of these decisions, they're not easy. There's a lot involved that goes into it, a lot of gray area and such. And it's just kind of like the summarization here of how ethics can go and such between crossing the law and then trying to be carry out ethics and stick to everything and such. So it's exactly why I have these ethics committees because have a whole committee dedicated to be able to consult for these kinds of decisions if there's questions and such. So.
Hello. For my reflection, what stood out the most to me in this case, in my opinion, was how difficult it can be to make end of life decision. When a patient's spiritual convictions, family feelings, and medical demands all collide, it is a very big thing. As the chaplain in this experiment, I discovered how crucial it is to listen beyond the medical details and try to comprehend what provides a patient with comfort, dignity, and serenity. I also came to see how much assistance families require in times of fear or overwhelm, and how spiritual principles can influence choices just as much as medical knowledge. Ultimately, this event made me realize that providing ethical treatment is about respecting the patient's identity as a person rather than ensuring their survival. Thank you so much for listening to our presentation. This is Group 8.